Good afternoon. Thank you for giving us an opportunity to speak here. It's a wonderful gathering here. Nice discussions, and my talk is probably rightly timed at this point of time. We've had a lot of discussions and other things. The case we are dealing with is a highly calcified distal SFA and a P3 lesion. The vessel is extensively calcified all across from the iliacs. There is wall calcification, but there is a calcified occlusion of the distal SFA. And the age of this patient is 42 years, who also happens to be my classmate, female patient. Now, if we see, there is an occlusion, but below there is flimsy flow in the tibials and pedal vessels, but there are no occlusions below. If we see this, the success of an intervention in anything depends on true lumen recanalization. And when we zoom up, we see that this calcification plaque, and there is a thin line which is actually the compressed true lumen. It is very important to negotiate the wire across this particular true lumen to have a proper outcome for this intervention. Now, with repeated attempts, the lumen is so small that even an O14 wire, it is difficult to track an O14 wire. But with some efforts, it is possible when we realize what is the direction of the true lumen in this particular scenario. It's a very tight calcification. With some effort, it does cross that lesion. Right. Now, subsequently, there is a distal lesion there, which again has some difficulties, but then we are able to cross it and park the wire in the common peroneal artery. But here, our microcatheter does not track. So we start using a coronary balloon, a 1.5 mm NC coronary balloon, to at least predilate so that our microcatheter tracks through. But even the coronary balloon doesn't track through that lesion. Then we increase the sheath to a 7 French sheath. This is an antegrade puncture. Now inside the 7 French sheath, we get a 6 French guiding catheter, and then we are able to push a coronary balloon and predilate it by 1.5 mm. Subsequently, we do a little bit of conjugacy. We want to use one balloon, so we take a 2.5 mm balloon and dilate the entire track. With the distal, there is another distal lesion there, entire track with a 2.5 mm balloon. Now, after the initial dilatation, this is the scenario. There is some improvement in the flow, but hardly any luminal gain. So, what would be the ideal thing here to do? I have no experience with IVL, and here the calcium is on one side, the other side wall is thin walled. It is normal. I do not know how an IVL would work, and the lumen gain is not much. Passing an IVL balloon might seem difficult in this scenario. So what would be the ideal solution here? Stent would not open.
Definitely not.
So what is your option, sir?
This patient is a claudicant, right?
No, sir. Sorry, I forgot. We don't treat claudicants.
No, I know.
This patient had a paronychia. The toenail was excised. She developed an ischemic ulcer there.
You see, I think
Since you've already started off with the angioplasty, I would increase
The bigger balloon?
bigger balloon and then
Okay.
because you're already committed, your costing is
See,
already.
sir, if I use a bigger balloon, I might cause dissections in the adjacent arteries. Now that is an area which I would not want to stent.
you see, one is are you in intraluminal or into subintimal?
It is intraluminal, sir.
You checked it out.
Yes, it is intraluminal.
But then use an atherectomy device.
Okay. Okay, and that is what we did. I am happy I am in consensus now. So we did the stealth atherectomy. So we went through initial 2 passes with the slow speed, medium speed. And this is after the first 2 passes, there was some amount of luminal gain. Now after the 3rd pass, there was significant luminal gain across those lesions. Now this is an area where we do not like to stent, because patient is young. We might have to do a bypass in the future below knee, one of the tibial arteries or what. We don't want to stent that area. So we decided to use a drug-coated balloon in this territory. It's a 5 into 150 millimeters drug-coated balloon. The drug-coated balloon we used, we have used both Medtronic's Impact as well as Lutonics. Lutonics is preferred in calcified lesions. Impact is preferred in atherosclerotic lesions. The reason is simple. Urea is more lipophilic, the excipient. It is more absorbed and retained in the lipid-rich atherosclerotic disease. While sorbitol, which is the excipient in Lutonics, has better affinity for calcium hydroxyapatite and better retained in calcified lesions. So this is the, after drug-coated balloon, this is the final outcome of the same lesion. And below knee, whatever was flimsy filled better. That blush is because of NTG we gave because there was some vessel spasm, but otherwise there was nothing. So for us, yes, there have been embolization. The same case there has been embolization. It is there on the laptop, but for some reason I cannot zoom it. That embolization right falls where I have 12 days trial period. I cannot zoom it and capture it. We can shearly flow some free floating particles in the arteries. There is initially cold feet. The wound seems to worsen for the first week, but those similar situations have happened with POBO also. Initially, when there is reperfusion, the wounds they are more prone for infections. There is edema. There is always worsening of the wounds, but none of the wounds have led to adverse outcomes. Wherever the salvageable wound is there, it has been salvageable. Wherever we have been able to amputate the toes for primary reasons, we have been able to amputate the toes and close it without any excess delay in the recovery period. So, of course, we have to embrace change because that is the only thing that is constant. And the first thing towards change is awareness. And the second step is acceptance. Thank you so much.